The other hormones, I like to give cortisol a personality to help organize its massive constellation of effects. You know those classmates of yours who, whenever you talk to them, seem to have some sort of a crisis going on at all times? Like every point deducted on a test will send them into a stress spiral? Perhaps that med student is you. Well, then you'll really relate to this one because for the purposes of this lecture, cortisol is the high-strung gunner. Our friend the gunner runs around with a sky-high blood pressure because of all the stress he's under. This is mainly mediated by increased surface expression of arteriolar alpha-1 receptors. Remember what those do? These are responsible for causing smooth muscle contraction, which effectively increases the systemic vascular resistance, thereby increasing the blood pressure. Our high-strung buddy's also having one breakdown after another. Cortisol beats even glucagon as far as its ability to break down or catabolize macronutrients. It causes not only gluconeogenesis, glycogenolysis, and lipolysis, but also insulin resistance and proteolysis, which glucagon doesn't do. While projecting an air of confidence, cortisol the high-strung gunner is extremely emotionally fragile. Cortisol the hormone mirrors this with structural fragility. It's uniquely important in that it causes bone and connective tissue weakening by inhibiting osteoblasts and fibroblasts respectively. Indeed, our friend cortisol is stressed so frequently that it makes him sick. We all know that constant stress can lower your immune system, and in fact, constant stress increases circulating cortisol levels. Cortisol is one of the most potent immunosuppressants in the body, and glucocorticoids are some of the most potent immunosuppressant drugs we can administer. It's no wonder that our poor, stressed friend pretty much always has a sniffle or a cough every time we see him. Finally, although nobody wants to say it, there's a fair chance that he's got some sort of an actual psychiatric disorder. Though this may not appear in your book, it's actually one of the most common effects of increased cortisol. Most often, high cortisol leads to anxiety or depression, as you might expect in any gunner, but in some circumstances it can lead to frank psychosis. Let's hope nothing pushes him that far. This concludes our introduction to cortisol the high-strung gunner. For you visual people, here's a diagram I made up to sum up what we just went over. A few things I want to clear up. First of all, cortisol requires a carrier molecule to be transported through the blood, and it uses a molecule known as corticosteroid binding globulin. Now why does it need a carrier molecule? Because it's a cholesterol derivative, remember? So it's lipophilic, meaning that it's not soluble in the largely aqueous blood. Second, since cortisol is a catabolic hormone, you might expect to see every person walking around with hypercortisolism looking pretty thin. But the tendency towards fat mobilization and insulin resistance leads to fat deposits in some pretty weird places. You'll learn more about this when we discuss Cushing's syndrome, but it's actually a very characteristic look. Next, let's go into a little bit more detail about what is arguably cortisol's most tested effect, the extremely potent blanket immunosuppression that it can cause. Cortisol can take out pretty much every single immune defense we possess. Can you remember one of them from biochemistry? Cortisol inhibits phospholipase A, effectively shutting down the production of the entire eicosanoid line, prostaglandins, thromboxanes, leukotrienes, you name it. It inhibits the production of IL-2, preventing the proliferation of T lymphocytes. It inhibits leukocyte adhesion, which prevents leukocytes from migrating to the site of infections. Side note, this counterintuitively elevates the white count because leukocytes can't attach to the tissue will demarginate and roam the blood aimlessly. Finally, cortisol takes down the atopic response by blocking histamine release from mast cells and decreasing the number of eosinophils. This global shutdown of the immune system makes cortisol extremely potent, but also very nonspecific. Finally, cortisol is also extremely important to know for step 1, and not just because of the random adrenal and pituitary tumors you might find. I'll give you an example of something you might see more frequently on this next flash quiz. A patient taking medications for which of the following conditions might experience early bone fragility? Rheumatoid arthritis, migraine headaches, or anxiety disorder? The answer is rheumatoid arthritis. And this is definitely a leading question. Of course, glucocorticoids are going to be involved in a section about cortisol, but it's a very common scenario in step 1. You'll see a person with an autoimmune disease who comes in with premature osteoporosis or some infection that he or she really shouldn't have, like TB. The important thing you need to be able to do is make the connection between the immunosuppressant medication he or she may be taking and the presenting symptoms. While a lot of different immunosuppressants increase the risk of infection, early bone weakness is pretty specific to glucocorticoids out of all other immunosuppressants. Now we're going to take another break from the hypothalamic pituitary hormones and talk a little bit about calcium regulation. Fortunately, this is a bit more straightforward than cortisol, so get excited. Now, if I were to ask you where you could find calcium in the body, where would you first look? If you said bones, you'd be right. That's where over 99% of the body's calcium is found. But the calcium we're primarily interested in this section is the fraction of a percent found in the blood, because maintaining this vital electrolytes concentration within a tight range is crucial in normal physiology. So where would you expect to find circulating calcium? Free calcium ions are certainly an option, and they make up about 45% of the circulating calcium. The remainder of the calcium is bound to either albumin, because it's negatively charged, or circulating organic anions, like phosphate. Now, because I know how much you all love chemistry, let's take a look at the sizable minority of calcium bound to anions. Free calcium is in equilibrium with the calcium bound to organic anions, like so, which means that they associate and dissociate in a ratio that's determined by how much of each is present in the blood. Starting to get flashbacks to chemistry yet? What would happen if, say, there were suddenly less of the organic anion available? It's kind of like the situation with thyroglobulin. With less anion to bind calcium, there will be more free calcium released. And it just so happens that there's a pathologic phenomenon that can decrease the amount of organic acid available to bind calcium. It's called more acid. Now hold on a minute, Arjun, says you. How the hell does more acid make less acid? Simple. If the blood pH decreases, by definition, there are more H+ ions in the blood. And just like the positive calcium can bind to the negative acid, positive hydrogen ions can also bind to the acid. You can think of H+ ions as competitive inhibitors of calcium binding. So what then does acidosis do to calcium? It causes hypercalcemia, as alkalosis causes hypocalcemia. Now, before taking step one, I would have thought this a really trivial point, but I swear to you, I swear this came up on my exam. That about covers it for what you need to know about the homeostasis between the different forms of circulating calcium. The fun part of regulation is how calcium enters and exits the body, and how it binds and leaves the bone. There are two main hormones responsible for the movement of calcium between these sites, vitamin D and parathyroid hormone. The most important thing to remember is that vitamin D is primarily concerned with obtaining calcium substrate for the bone, whereas parathyroid hormone is primarily concerned with increasing serum calcium. Vitamin D is another hormone that comes from cholesterol, just like the steroids. You can either ingest the inactive hormone or use the sun's energy to synthesize it from the cholesterol in your skin, though I wouldn't suggest that to a dermatologist as they're likely to get an aneurysm. The inactive hormone requires two hydroxylation steps. The first one occurs in the liver, and the second one occurs in the kidneys. Failure of either step will result in a vitamin D deficiency. When it's served its purpose, vitamin D is inactivated, when one hydroxyl group is moved over to the 24. When having a discussion about calcium regulation, it's impossible to exclude phosphate. Now why is that? Because calcium and phosphate create the majority of the mineral hydroxyapatite, the major mineral component in bone. So in order to deposit calcium onto the bone, you need phosphate as well. Remember what I said the purpose of vitamin D was? To ensure adequate substrate for bone synthesis. To that end, vitamin D stimulates increased absorption of both calcium and phosphate from the gut, providing the substrate that allows osteoblasts to mineralize the bone. Meanwhile, it also prevents the kidneys from wasting calcium by excreting it in the urine. Paradoxically, it seems, vitamin D also increases the activity of osteoclasts, the cells that break down the bone. Now, why might a hormone that promotes the acquisition of bone substrate break that bone down again? It's called remodeling. The microtrauma of everyday wear and tear causes inorganic structures to erode quickly, but because bone is living tissue, it can avoid that wear and tear to some extent by constantly turning over. Vitamin D's regulation makes a lot of sense for the most part. The rate-limiting step is the final hydroxylation in the kidney, and it's stimulated by low calcium and phosphate. What's not immediately intuitive is that it's also stimulated by parathyroid hormone, the hormone that's known for ripping calcium off the bones themselves just to boost the circulating calcium. We'll talk about why this actually makes a lot of sense, but first, let's get a better idea of what PTH is all about. Remind me again, what's the ultimate goal of parathyroid hormone? The goal of parathyroid hormone is to increase blood calcium at all costs, even at the cost of stripping it from the bone. Parathyroid hormone strongly promotes osteoclast activity, breaking hydroxyapatite into calcium and phosphate. A couple notes about this mechanism that are fair game for step 1. Osteoclasts don't actually have a PTH receptor, but they do have a receptor responsible for their activation called rank. The hormone that activates osteoclasts, rank ligand, is actually secreted by the osteoblasts and osteocytes, which do have PTH receptors. So PTH indirectly causes increased osteoclast activity by causing osteoblasts and osteocytes to secrete rank ligand. Like vitamin D, PTH stops the kidneys from excreting calcium. However, it also promotes phosphate excretion. Now hold on there, PTH, what do you got against phosphate? Remember, simply providing the phosphate and calcium as substrate for the osteoblasts, like vitamin D does, promotes the deposition onto bone, or worse yet, spontaneous mineralization of calcium phosphate onto blood vessels. If PTH wants to have more calcium in the blood, sorry phosphate, but you're going to have to go. Finally, PTH actually stimulates vitamin D activation, which confuses a lot of people because they think of PTH as kind of the anti-vitamin D, which is totally not true, by the way. These guys are partners in crime. They're BFFs. PTH has the immediate plan for increasing the blood calcium, but isn't concerned with pesky things like sustainability. While the bones have a lot of calcium to spare, we kind of need them to, support us and stuff. It's kind of like chopping apart bits of your house for firewood. I mean, sure, it's a decent fix in the short term, but sooner or later, you're going to have to go out and get yourself some actual wood for both the fire and the bits of your house that you just ruined. How does vitamin D help fit that bill? By stimulating gut absorption of both phosphate and calcium. That way, you can rebuild the bone, and if it's too much phosphate for PTH, it can always tell the kidneys to go out and excrete some more. The regulation for PTH makes a lot less sense than that of vitamin D. It's stimulated by low calcium and high phosphate, which makes sense from a feedback perspective, but here's where it gets a little kooky. It's also regulated by magnesium. Low magnesium, like its divalent brother calcium, leads to increased PTH. But to make matters really weird, really low calcium actually inhibits PTH. So why is this clinically relevant? Because magnesium derangements can lead to PTH derangements. Most commonly, severe hypomagnesemia leads to clinically significant hypoparathyroidism, because mild hypomagnesemia tends to correct itself. There's a lot of things that can cause magnesium wasting. Diarrhea, diuretics, alcohol abuse, aminoglycosides, those are just a handful of them. Now, what labs would you expect to see in a hypoparathyroid patient? Hypocalcemia and hyperphosphatemia, right? Just remember that in these patients, correcting the magnesium is essential to correcting the calcium and the phosphate. The final hormone in calcium regulation is calcitonin, and compared to the others, this one doesn't really get any love on step 1. It has absolutely nothing to do with phosphate, but as far as calcium goes, this one acts pretty much like the anti-PTH. Its goal is to decrease blood calcium in response to elevated levels of calcium. It stops the osteoclasts from breaking down the bone, stops the gut from absorbing calcium at all, and actually stimulates the kidneys to excrete calcium. And while it may seem like you need the yin of calcitonin to counteract the yang of parathyroid hormone, calcitonin's not really that functional in humans. It's like the appendix of the pinky toe, vestigial. When the body needs less PTH activity, the main way it goes about that is to just decrease the secretion of PTH. Interestingly enough, since our calcitonin is so non-functional, the pharmacologic calcitonin you can use in hypercalcemic patients is derived from, you'll never guess, salmon calcitonin. The more you know. And just like that, we're done with calcium regulation. I hope you're ready to test your knowledge, because it's time for another flash quiz. Question: a chronic smoker is found to have hyperparathyroidism secondary to lung cancer. Would you expect the following values to increase or decrease? First, bone density. Second, serum phosphate. Go ahead and pause this if you need some time to think about it. And the answer is decreased bone density and decreased serum phosphate. So, the clinical scenario I just gave you for hyperparathyroidism is extremely common on step 1. Several types of cancer, most notably squamous cell lung cancer, secrete an abnormal analog of parathyroid hormone called PTH-RP. parathyroid hormone-related protein. And they do so in a completely unregulated manner. Clinically, the syndrome mirrors hyperparathyroidism, causing decreased loss of calcium in the urine, decreased calcium on the bones, leading to decreased bone density, and urinary phosphate loss that leads to decreased serum phosphate. The one difference is, because the effects of PTHRP cause increased serum calcium and decreased phosphate, by negative feedback inhibition, the actual parathyroid glands backs way off and almost completely stops secreting PTH. Definitely remember this clinical scenario and think back to it when you're on the respiratory section, because it comes up a lot. And it's not the only lung cancer that causes a paraneoplastic syndrome. Small cell lung carcinoma can secrete two endocrine hormones that both begin with an A: antidiuretic hormone and ACTH. We're going to be going over those in the pathology section of endocrine. Congratulations, you finished up with a physiology of the major endocrine pathways. We're going to do one last mini-section on the different types of signaling pathways used by the different hormones, and then you're done with endocrine physiology. Go ahead and give yourself a pat on the back for that.